My topic is calcified nodule in percutaneous coronary intervention and its therapeutic challenges. To start with, introduction. It was first described in IOS study in 1996. It's a specific type of heavily calcified lesion that protrudes into the coronary artery lumen, and it's high prevalence in aging population. Intravascular imaging can differentiate between calcified lesion and calcified nodule. That's the only modality, and with intravascular imaging only we can make out whether it is calcified nodule, confirm it.
So IVAS is must.
Yes, sir, IVAS, and better is OCT. OCT will be 100%.
What about CT scan?
CT scan, sir, frankly speaking, in this article there was no mention about CT, but 100%.
Again, anything more than 2.5 या 3 मिलीमीटर होगा तो ही दिखेगा.
Yes, sir.
CT scan का requirement.
Yes. तो इसलिए IVAS और OCT की बेस्ट है सर. OCT 100% क्लियर हो जाता है सर. IVAS में भी कई बार डाउट आ जाता है. So percutaneous coronary intervention remains the therapeutic challenge in patients with increased risk of adverse outcomes. Types of calcified nodules. One is eruptive calcified nodule, and second is non-eruptive calcified nodule. To start with, eruptive calcified nodule has a disrupted fibrous cap with the presence of with or without thrombus over it, and non-eruptive calcified nodule has intact fibrous cap with no thrombus over it. So this eruptive calcified nodule is presented in many patients with acute coronary syndrome with the presence of thrombus. So sorry for the some bad image quality. This is IVAS and this is the OCT image. This is the OCT image with the coronary vessel lumen, and here you can see this is a eruptive calcified nodule with a irregular margin, and this is a non-eruptive with a well-defined fibrous gap over it, and this is the IVAS image, and here also you can see this is eruptive this calcified nodule which is coming into the coronary lumen, and this is non-eruptive which is very much well defined.
नोड्यूल के साइज के बारे में देखा कि इतना होता है उसको कोई नोड्यूल बोलेंगे. Any specific definition?
No sir, they are not specified. Usually it's very small only.
क्योंकि ऐसे भी एंजियोग्राफी में ऐसे बम तो दिखता ही है ना.
Yes sir. I'm coming next to it, sir. Like how this nodule is formed basically. It's in the calcified vessel. There is a certain point where I will come next to it.
So how will you differentiate plaque and nodule?
Plaque and nodule, sir. Sir, nodule will be a big protrusion into the vessel lumen, into the coronary vessel.
Plaque will not protrude?
So that will be having well defined. If you see a OCT image, there will be calcium will be differentiated with the. If you see a plaque, there will be a lipid core, and if you see a nodule, calcified nodule, there will be a lot of calcium over it.
So majorly plaque will be fibrofatty tissue, nodule will be calcified. That is what you are trying to say?
It's heavily calcified. It's
Okay.
heavily calcified. So coming to the epidemiology, calcified nodule accounts for 2 to 7% of patients with myocardial infarction. They present with incidence is around 2 to 7%, and prevalence among unstable angina patients is around 17%. Calcified nodule identification is around 22% in calcified patients who are undergoing treatment with intravascular imaging and other calcium modification techniques such as IVL or atherectomy. So,
But retrospectively, can you judge that after patient comes with an acute coronary syndrome and you did angio and all types of imaging modality,
yes.
will you be able to judge this the nodule was the culprit and after that 100% blockage of the artery, is it possible to judge?
Sir, initially we do angiography for everyone. With angiography, how to diagnose with angiography and how to see it, I am coming next to it. So, our first modality is to do angiography immediately. And with angiography, how to make out the diagnosis of this nodule that I will come next.
The pre-existing ટેસ્ટિંગ આ હશે એવું તમે કહી શકો.
Yes, sir. Calcified lesions, many of the calcified lesions we can see with the fluoroscopy itself. And in the calcified lesion, if we found that some thrombus-like thing, or some that I'll show you the image also.
Yeah.
So that we can make out that yes, this is a nodule.
So that thrombus is formed on the nodule rather than a new thrombus, right?
No, sir. It's basically what happens. Like it's a there is this collagen matrix inside the vessel wall, and there is a lot of calcium deposition. And at some point, the collagen matrix is absent, and that leads to this protrusion of calcium into the lumen of the coronary artery. So that exactly the pathophysiology. I am coming next to it. So the incidence of calcified nodule is high prevalence in patients with old age, females, diabetic patients, patients who are underwent prior CABGs and kidney disease. So calcified nodule are most frequent at the site of hinge motion, at the site of hinge motion of a severely calcified coronary vessels, such as ostial RCA or the mid RCA, and areas where there is a high lipid burden and necrotic core, such as left main coronary bifurcation and the proximal coronary tree. So these are the areas where we can find the chances of calcium nodule.
Take the previous slide.
Yes, sir. So these are the points where we can find the calcified nodules at the because of this things. Next time coming to it. So histopathology of the calcified nodule. In eruptive calcified nodule, there is a disruptive fibrous cap and with the luminal thrombus over it, which can be with thrombus or without thrombus. And there is with multiple nodular calcium fragments that penetrates the fibrous cap and comes inside the vessel lumen. So there is a disruption of endothelial monolayer of the coronary vessels.
Is it possible to have without thrombus? Disrupted fibrous cap, okay, and there cannot be thrombus. Is it possible?
No, sir. Means eruptive one will be definitely most of the times will be thrombus, because once it erodes the endothelial layer, thrombus will come
That
down.
to be there, no?
Yes.
So in eruptive thrombus will always be there, right?
Yes.
Smaller or bigger, whatever.
Yes. And sometimes over a period of time, suppose this eruptive heals and it
Then it
converts
might
into
dislodge.
yes, a non-eruptive. That also. So in non-eruptive one, there is a thick intact fibrous cap that separates the calcium from the vessel lumen, and there is no adherent thrombus over it. So it's an intact endothelial monolayer. This is a non-eruptive type of calcified nodule. Sorry for the image quality. This is an image of eruptive calcified nodule with the irregular margins and which is invading the vessel lumen. And this one is with non-eruptive with a well-defined fibrous cap and coming into the vessel lumen. So pathophysiology of the calcified nodule: at hinge point within the coronary artery, the tensile strength is reduced because of the relative absence of collagen matrix. So absence of collagen matrix at the area of calcium where there is an extensive calcium, and due to this eccentric calcium, with the calcified necrotic core, the collagen-free calcium is more susceptible to external mechanical forces, which causes fracture and the protrusion of calcium through the fibrous cap. So at this places where the mechanical forces are more, this calcium breaks down and it penetrates into the vessel lumen. This is the pathophysiology for the calcified nodule. And fractured calcium can damage the surrounding capillaries, which can lead to intraplaque hemorrhage also. And this rapid luminal gnawing can cause acute coronary syndrome. The patient comes with acute coronary syndrome in these patients. And over a period of time, if it is not treated well, there will be this intraplaque hemorrhage will be converted into osteogenic transformation of the blood component, leading to callus formation at this area. and which is covered with the neointima over a period of time, and it can be converted into non-eruptive calcified nodule. So this can happen if it is not treated at the eruptive phase. So protrusion of the non-eruptive calcified nodule due to the underlying lipid, it can be due to protrusion can be due to lipid base and the or the calcific base also. So this is the image, this is the aorta, this is the ostium, and this is a place where there is a lot of calcium, the sheets of calcium, and here there is a necrotic core calcium, and at this point, at this hinge point, first things happen like if there is this is a eruptive calcified nodule where there is destructive cap with thrombus, and there is increase in the plaque volume, luminal stress, and if it is not treated, then it healed and it converts into the non-eruptive calcified nodule, and with the resolution of hemorrhage, intraplaque hemorrhage, and the osteogenic transformation. And this is another one which is where there is a lipid base, and another this non-eruptive calcified nodule where there is a calcific base. So this non-eruptive calcified nodule can be with the lipid base, or it can be with the calcified base. So what is the role of
whether this kind of phenomena,
yes,
calcified nodule,
yes,
is restricted to coronary arteries, or it is a diffuse vascular phenomena occurring in the cerebral vessels, peripheral vessels, kidney, renal vessels? Because ultimately these shearing forces are everywhere.
yes.
You said where the branch takes place, the shearing forces are bound to occur. So whether it is restricted to coronaries, it can happen anywhere in the body.
Other places, I don't know, but in because of the movement of the heart, at certain points of the vessels, there is a lot of mechanical stress. So this calcium usually breaks down there. And
Because plaque formation is everywhere.
yes. So coming to the role of intravascular imaging, it's very important to recognize the presence of calcified nodule for the treatment strategy and the long-term outcomes after angioplasty. So angiographic diagnosis is very challenging. Presence of angiographic radiolucent mass in angiographic by fluoroscopy predicts the presence of calcified nodule, and which is confirmed in the OCT in one of the trials. There is one prospective trial in that they have confirmed that by angiography they have found that there is a radiolucent mass, and which is found to be with a calcified lesion. So they have found that it was confirmed with the OCT. So this is the image where with the angiography itself we found that there was some calcium there in the fluoroscopy, and which this one there was a dilatation with the balloon, and the results with a good non-compliant balloon also the dilatation was not sufficient, and then with the OCT there was a confirmation that there is a non-eruptive this one calcified nodule. This is with the angiography, this one, and this is another image where we can see there is a guide wire inside the coronary vessel, and here we can see there is a radiolucent mass, and which got confirmed by OCT that yes, this is a calcified nodule. So this is
The previous slide was of our patient, or it is a textbook slide? Previous slide.
no, it's not our patient, sir. It's a text.
So was there any discussion of the how that presented last patient? Ani pelani slide lo
Yes, sir.
take the previous. How this patient presented?
So they have not mentioned anything details about they have not mentioned.
Oh.
So this was the point, sir, what you were asking. By angiography we can see whether this is very difficult to make out whether it is a thrombus or whether it is a calcified nodule. By making a doubt on the angiography and then doing a OCT
is the manifestation of this calcified nodules, clinical manifestation?
So this was actually from the image I have taken from the journal only, and they have not mentioned anything detailed.
No, but let us assume. The vessel coming from above, is it LED?
Actually, this was the only image. At this part only they have focused it. So probably it's a LED which is coming, or it's a circumflex with a one branch like that.
So that calcified nodule will be causing obstruction to the branch which is getting originated, or the original main vessel where it will cause obstruction?
No, sir. It is obstructing the main vessel only.
So this is not a big obstruction to lead any symptom. Doesn't look like even 50%. Does it?
તમે ગાઈડલાઈન તો આખો ગયો છે ને ત્યાં.
Yes, yes.
It doesn't look like acute coronary syndrome at all.
No, sir. I am not at all telling that it's acute coronary
So
syndrome.
my question was in regard to acute coronary syndrome. એકવાર પેશન્ટ એમાં લઈને આવી ગયું ને તમે એન્જિયોમાં લીધું,
Yes.
પછી તમને ખબર પડે કે જે ઓલરેડી 100% બ્લોક થઈ ગઈ છે.
Yes, sir. If it is a 100% occlusion, then it's very difficult to make out by a
So that was my question.
Okay, sir.
Right? Okay, કારણ કે આ તો હવે આ તો ઠીક છે, આનું ડિસ્ક્રિપ્શન ના હોય એવું બને નહીં. તમે જોજો આ આર્ટિકલમાં ડિસ્ક્રિપ્શન હશે આ વેસલનું. But how this patient actually presented? What was the symptom? આ બાજુની આર્ટરી ન હતો કે આ મેઇન આર્ટરી ન હતો એ જાણવું જરૂરી છે.
I thought you were asking how to see. Okay. Once the vessel is 100% blocked, sir, then
આપણે તો પ્રભુ 100% બ્લોક થાય પછી જવાનું જ ને ત્યાં લગી તો
only after opening it and making a way, then only we can make out whether it is a nodule or not.
Okay.
So this is images with the advanced fluoroscopy image. Like cath labs, we have this stent boost facility, and with that also we can make out, and by confirming with the OCT, that this is a patient who underwent angioplasty with a wire and the balloon inside. While during the pre-dilatation, in spite of high pressure dilatation, this part of the vessel, this part of the lesion is not getting open, and which got confirmed with the this one stent boost facility what we have. And and this with the OCT image, we found that yes, this is a non-eruptive calcified nodule, which got confirmed with the advanced fluoroscopy. And again, this patient also, while doing angioplasty only, it got that we noticed that calcified nodule is there. So the role of intravascular angiographic appearance of a calcified nodule is similar to thrombus, making a diagnosis very difficult in ACS patients. Routine use of intravascular imaging is important to identify the calcified nodule. High definition IVUS may better visualize the fibrous cap, but it's very difficult to discriminate between two types of calcified nodules with IVUS, with high definition IVUS. So the OCT with the IVUS, this is the image. This is a eruptive, and this is a non-eruptive with the IVUS image, which is not that clear. Sorry. So coming to the OCT, OCT provides more certainty in the evaluation of the calcified nodule because of superior resolution. Both types of calcified nodules have significant superficial signal attenuation on OCT, which differentiate them from isolated protruding calcium. So this is the OCT image, where you can see this is well-defined fibrous cap with no thrombus over it. This is a non-eruptive calcified nodule, and this is with an irregular margin. This is eruptive calcified nodule, and with an irregular fibrous cap, and along with that some thrombus over it. So OCT make the image and makes the diagnosis very much clear, and confirm it that yes, this is a calcified nodule in the coronary vessel. So, and this is the image of again the non-eruptive calcified nodule, and this one obstructing the lumen. So challenges in the treatment of calcified nodule. Patients with calcified nodules have worse outcome after PCI than those without calcified nodule. Instead calcified nodule protrusion and regrowth of the calcified nodule likely predominant mechanism of failure post PCI. So main reasons like there can be stent fracture, there can be stent under expansion, and there can be stent failure also, which leads to high incidence of cardiac vessel revascularization in future. vessel wall, eccentric expansion of the balloon to modify the calcified nodule, and with the drawbacks of balloon angioplasty is insufficient force, which leads to stent under expansion and stent asymmetry. So balloon angioplasty will have a lot of limitations. Atherectomy, how it will help? It will debulk and modify the severely calcified lesion and the nodule, and larger bursts are required in atherectomy which are more effective in calcified nodule, and orbital atherectomy is more useful than rotational atherectomy. So this is an image with a patient who underwent atherectomy. This is a pre-atherectomy image of a OCT, and with the atherectomy, this is the burr for the orbital atherectomy, and post-atherectomy, you can see there is a debulking of this calcified nodule, and the lumen area has been increased. So this is another image of rotational and orbital atherectomy, where there is a final improvement of lumen area post atherectomy. So coming to IVL, intravascular lithotripsy, in this advantages, energy is distributed circumferentially, so the disruption of calcium is in the uniform manner, and also it modifies the deep calcium surrounding the calcified nodule. So it gives a better result after angioplasty. This is an image where atherectomy and IVL both were done. So atherectomy patient, this is the image, and the final result post stent deployment. After deployment of the stent, you can find there is some protrusion of the nodule still after stenting. But in intravascular IVL lithotripsy, you can find a good result with a good approximation of the stent with the vessel, and the final good lumen area is achieved. So ideal therapy will be for calcified nodule will be dual therapy, going with the atherectomy as well as IVL both together in patients with calcified nodule. Atherectomy able to debulk the collagen-rich calcium sheets at the site of the calcified nodule, and is more amenable to fracture by IVL. Better stent expansion is achieved, and there is a reduced incidence of target lesion revascularization if we do this dual therapy for the calcified nodule. So this is an image where eruptive calcified nodule, and after post-treatment, this is the final post-stent implementation, and this is the deformable non-eruptive calcified. And these are the patients who underwent dual both atherectomy as well as IVL therapy, and the good stent approximation is achieved. So another modality is drug-coated balloon. At this hinge point location of the because of the location of the calcified nodule, this can be used drug-coated balloon nowadays. It can be used in patients who are very high risk for stent failure, and there is a risk of recoil and regrowth of calcified nodule even after balloon dilatation with the drug-coated balloon. Can be useful in patients with instant restenosis in the calcified. If the patient comes again after instant restenosis, drug-coated balloon can be another option instead of putting another stent inside the stent. So we can go for drug-coated balloon. Another option is covered stents. This prevents the protrusion of the erupted calcified nodule into the lumen, so thus prevents the instant restenosis in future. But this role is very limited, and there is a need of further trials to tell this about this, how useful the covered stents are. So how the therapeutic approach should go for a calcified nodule? Erupted calcified nodule is more deformable. Preparation with a one-to-one non-compliant balloon, IVL therapy, and along with the atherectomy, it gives excellent stent expansion, and we can repeat angiography after a couple of months to see is there any protrusion back into the vessel lumen.
Yes, intravascular brachytherapy.
Intravascular brachytherapy. So that is not most of the time we use. We use usually IVL and atherectomy both.
erupted vessel, intravascular brachytherapy.
So in non-eruptive calcified nodules, which are less deformable, some are lipid based which are deformable and some are calcific based which are non-deformable. So IVL with high pressure inflation and along with atherectomy is required for patients with non-eruptive with a calcific base. So this is how to approach a calcified nodule on intravascular imaging by confirming whether there is a fibrous cap which is disrupted or regular or with a direct thrombus. If yes, thus it is eruptive. So high pressure inflation with 1:1 size NC balloon. So NC balloon expansion into orthogonal view, full expansion, deformable, and then put a drug-eluting stent. So this is ideal scenario. And if it is a non-eruptive and there is a partial expansion with a non-compliant balloon, then with a single preparation we can go for either large one atherectomy or IVL with a high pressure inflation again, and then if we get a full expansion which is deformable, then we put a drug-eluting stent. If along with this, if atherectomy or IVL is not useful, then we go for a dual preparation, dual atherectomy or with IVL, then go for NC balloon. And if still there is a partial expansion, we are not able to dilate it fully, then we think of either drug-eluting stent or drug-eluting balloon, drug-coated balloon. And a repeat angiography if it is required, if we have not achieved the good results. So this is overall descriptions what I told just now. This is erupted, and this is some like how what are the intervention strategies, and this is the non-eruptive one with this other different strategies for this. So coming to the conclusion.
Please take the previous slide. What was the last slide?
Yes.
So in eruptive there is more target lesion revascularization because they are deformable, but worse prognosis among ACS.
Yes.
And in the non-eruptive it is less target vessel because they are not deformable,
Yes.
right? But they have not commented on prognosis.
Yes.
That was a very important point, I guess.
Yes.
Isn't it?
Yes. Because eruptive, there is a high chance of protrusion even after putting a stent. Through the stent studs, there is protrusion of this calcified nodule into the vessel. So even after dilatation, we won't be able to do anything. Then in these patients, there is a chance of restenosis, stent thrombosis is high.
So any number of percentage that we can say that in eruptive this much chances of restenosis, in non-eruptive this much chances.
So
Anywhere it is mentioned?
no, so they have not done any study directly with like any patients who are undergone PCI with atherectomy or IVL, and then they found there is a need of further study for this. This calcified nodule itself, they have highlighted now that this also can be a.
But the point is the eruptive calcified nodule is not good.
Yes, definitely. It's not good. Especially even after putting a stent, if there is a protrusion into the vessel lumen, so that's not a good sign. That's not a healthy sign. There is a chance of restenosis or in future.
And ACS lesion prognosis is what because most of them are very acute.
Yes.
Right? So that is almost always will cause a catastrophe.
Yes. In that case, we have to do it. Otherwise, yes. So coming to the conclusion, eruptive and non-eruptive have distinct histopathological and prognostic features. Use of intravascular imaging, especially OCT, enables differentiation between two types. Optimal interventional treatment is required. Understanding the role and the limitation of each therapeutic strategy is required, and further clinical studies